Good day everyone, this is Dr. Alson Cabarles, and in this lecture we are going to discuss about the basics of arterial blood gases. At the end of the lecture, the student should be able to discuss what is ABG and its importance, discuss the physiology behind arterial blood gases, enumerate and discuss the basic ABG abnormalities, interpret ABG findings, and assess the adequacy of the compensatory response to primary ABG disturbances. Arterial blood gas analysis. Arterial blood gas or ABG analysis refers to the measurement of pH and the partial pressures of oxygen and carbon dioxide in arterial blood. From these values, we can assess the state of acid-base balance in blood and how well lungs are performing their jobs of gas exchange. Pulmonary gas exchange, a physiology review. We know that our cells use oxygen to generate energy and produce carbon dioxide as waste. Blood supplies cells with the oxygen they need and clears the unwanted carbon dioxide. This process depends on the ability of our lungs to enrich blood with oxygen and rid of its carbon dioxide. Pulmonary gas exchange refers to the transfer of oxygen from the atmosphere to the bloodstream or oxygenation, and carbon dioxide from the bloodstream to the atmosphere or carbon dioxide elimination. The exchange takes place between the tiny air sacs called alveoli and blood vessels called capillaries. Because they each have extremely thin walls and come into very close contact, carbon dioxide and oxygen are available to move or diffuse between them. Arterial blood gases help us to assess the effectiveness of gas exchange by providing measurements of the partial pressures of oxygen and carbon dioxide in arterial blood. Partial pressure describes the contribution of one individual gas within a gas mixture, such as air, to the total pressure. When a gas dissolves in liquid like that of blood, the amount dissolved depends on the partial pressure. Gases move from areas of higher partial pressure to lower partial pressure. At the alveolar capillary membrane, air in alveoli has a higher partial pressure of oxygen and lower partial pressure of carbon dioxide than capillary blood. Thus, oxygen molecules move from alveoli to blood and carbon dioxide molecules move from blood to alveoli until the partial pressures are equal. Carbon dioxide elimination. Diffusion of carbon dioxide from the bloodstream to alveoli is so efficient that carbon dioxide elimination is actually limited by how quickly we can blow off the carbon dioxide in our alveoli. Thus, the partial pressure of carbon dioxide in the blood is determined by alveolar ventilation, the total volume of air transported between alveoli and the outside world every minute. Ventilation is regulated by an area in the brainstem called the respiratory center. This area contains specialized chemical receptors that sense the partial pressure of carbon dioxide in the blood and connect with the muscles involved in breathing. If it is abnormal, the respiratory center adjusts the rate and depth of breathing accordingly. Normally, lungs can maintain a normal partial pressure of carbon dioxide in the blood even in conditions where carbon dioxide production is unusually high. Consequently, an increase in partial pressure of carbon dioxide in the blood virtually always implies reduced alveolar ventilation. Hemoglobin-oxygen saturation. Oxygenation is more complicated than carbon dioxide elimination. The first thing to realize is that the partial oxygen pressure does not actually tell us how much oxygen is in the blood. It only measures free unbound oxygen molecules, a tiny portion of the total. In fact, almost all oxygen molecules in blood are bound to a protein called hemoglobin. Because of this, the amount of oxygen in blood depends on the following two factors. First, hemoglobin concentration. This factor determines how much oxygen blood has the capacity to carry. And two, saturation of hemoglobin with oxygen. This factor is the percentage of available binding sites on hemoglobin that contain an oxygen molecule. For example, how much of the carrying capacity is being used. Oxyhemoglobin dissociation curve. We now know that the amount of oxygen in the blood depends on the hemoglobin concentration and the saturation of hemoglobin with oxygen. So what is the significance of the partial pressure of oxygen? partial pressure of the oxygen can be thought of as the driving force for oxygen molecules to bind to hemoglobin. As such, it regulates the saturation of hemoglobin with oxygen. The oxyhemoglobin dissociation curve shows that the saturation of hemoglobin with oxygen that will result from any given partial pressure of oxygen. In general, the higher the partial pressure of oxygen, the higher the saturation of hemoglobin with oxygen, but the curve is not linear. Note that with a normal partial pressure of oxygen at the arterial system of approximately 13 kilopascals or about 100 mm mercury, hemoglobin is more or less maximally saturated with a partial pressure of oxygen dissolved in the arterial system of more than 95%. This means that blood has used up its oxygen carrying capacity, and any further increase in the partial pressure of oxygen in the arterial blood will not significantly increase the arterial oxygen content. Hypoxia, hypoxemia, and impaired oxygenation. These terms are often used interchangeably but meant different things. Hypoxia refers to any state in which tissues receive an inadequate supply of oxygen to supply normal aerobic metabolism. It may result from either hypoxemia or impaired blood supply to tissues. It is often associated with lactic acidosis as cells resort to anaerobic metabolism. Hypoxemia. This refers to any state in which the oxygen content of the arterial blood is reduced. It may result from impaired oxygenation, low hemoglobin, or reduced affinity of hemoglobin for oxygen. Impaired oxygenation. This refers to hypoxemia resulting from reduced transfer of oxygen from lungs to the bloodstream. It is identified by a low partial oxygen dissolved in the arterial system of less than 10.7 kilopascals or less than 80 mm mercury. The basics of acid-base balance. The terms acidity and alkalinity simply refer to the concentration of free hydrogen ions in a solution. Hydrogen ion concentration can be expressed directly in nanomoles per liter or as pH. Solutions with high hydrogen ion or low pH are acidic, and those with low hydrogen ion or high pH are alkaline. The point at which a substance changes from alkali to acid is the neutral point, with a pH of 7 and hydrogen concentration of 100 nanomoles per liter. An acid is a substance that releases hydrogen ion when it is dissolved in a solution. Acids therefore increase the hydrogen ion concentration of the solution, thus lowers the pH. A base is a substance that accepts hydrogen ion when dissolved in the solution. Bases therefore lower the hydrogen ion concentration of a solution, thus raising the pH. A buffer is a substance that can either accept or release hydrogen ion depending on the surrounding hydrogen ion concentration. Buffers therefore resist big changes in hydrogen ion concentration. So what is pH? The pH or power of hydrogen scale is a simplified way of expressing large changes in the hydrogen ion concentration. It is a negative logarithmic scale. The negative means that the pH values get lower as the hydrogen ion concentration increases. So for example, a pH of 7.1 is more acidic than 7.2. The logarithmic means that the shift in pH by one number represents a tenfold range in hydrogen ion concentration. For example, 7 is 10 times more acidic than 8. What generates hydrogen ions in our bodies? The breakdown of fats and sugars for energy generates carbon dioxide, which, when dissolved in blood, form carbonic acid. Metabolism of protein produces hydrochloric acid, sulfuric acid, and other so-called metabolic acids. Hydrogen ions must therefore be removed to maintain normal blood pH. But what removes hydrogen ions from our bodies? There are two mechanisms. The first one is the respiratory mechanism. Our lungs are responsible for removing of carbon dioxide. PaCO2, or the partial pressure of carbon dioxide in our blood, is determined by alveolar ventilation. If carbon dioxide production is altered, we adjust our breathing to exhale more or less carbon dioxide as necessary to maintain the partial pressure of carbon dioxide in the blood within normal limits. the bulk of the acid produced by our bodies is in the form of carbon dioxide. So it is our lungs that excrete the vast majority of the acid load. Renal mechanisms. The kidneys are responsible for excreting metabolic acids. They secrete hydrogen ions into the urine and reabsorbs bicarbonate from urine. Bicarbonate is a base and therefore accepts hydrogen ion, so it reduces the concentration of hydrogen ion in the blood. The kidneys can adjust urinary hydrogen ion and bicarbonate excretion in response to changes in metabolic acid production. However, the kidneys do not just regulate acid-base balance. They must also maintain stable concentrations of the major electrolytes like the sodium and the potassium and try to preserve electron neutrality. The need to perform these other tasks can sometimes interfere with pH regulation, either driving disturbances of acid-base balance or preventing their correction. The following equation is crucial to understanding acid-base balance. Water plus carbon dioxide will give off carbonic acid, which eventually dissociates to hydrogen ion and bicarbonate. First, this equation shows that carbon dioxide, when dissolved in blood, becomes an acid. The more carbon dioxide added to blood, the more carbonic acid is produced, which dissociates to release free hydrogen ions. Second, it predicts that blood pH depends not on the absolute amounts of carbon dioxide or bicarbonate present, but on the ratio of the carbon dioxide to bicarbonate. Thus, a change in carbon dioxide will not lead to a change in pH if it is balanced by a change in the bicarbonate that preserves the ratio, and vice versa. Because carbon dioxide is controlled by respiration and bicarbonate by renal excretion, this explains how compensation can prevent changes in blood pH. There are two major balancing acts that influence acid-base regulation. The first one is sodium ions are retained by swapping them for either a potassium or hydrogen ions. When potassium is in short supply, hydrogen ions has to take up the slack and vice versa. And therefore, more hydrogen ions are excreted in exchange for sodium. Number 2. Chloride and bicarbonate are the main negatively charged ions or anions that have to balance with positively charged ions or cations, which are predominantly sodium and potassium. During times of high chloride loss, more bicarbonate is retained. When bicarbonate losses are high by the kidney or gastrointestinal tract, more chloride is retained. Therefore, generally speaking, potassium and hydrogen ions levels have a tendency to move in the same direction, whereas a primary fall in either chloride or bicarbonate will usually cause the other to move in the opposite direction. Disturbances of acid-base balance. An acidosis is any process that acts to lower blood pH. If it is due to a rise in partial pressure of carbon dioxide in the blood, it is called a respiratory acidosis. If it is due to any other cause, then bicarbonate is reduced and it is called metabolic acidosis. An alkalosis is any process that acts to increase blood pH. If it is due to a fall in the partial pressure of carbon dioxide in the blood, it is called a respiratory alkalosis. If it is due to any other cause, then bicarbonate is raised and it is called metabolic alkalosis. When faced with an ABG, how can we tell which is the primary disturbance and which is the compensatory process? The first rule to remember is that overcompensation does not occur. The midpoint of the acid-base scale lies at a pH of 7.4 with an hydrogen ion of 40. If the scales tip towards acidemia or a pH of less than 7.4, this suggests a primary acidotic process. If they tip towards alkalemia or a pH of greater than 7.4, a primary alkalotic process is likely. The second rule is that the patient is more important than the ABG. When considering an ABG, one must always take account of the clinical context. For example, if the patient were a diabetic with high levels of ketones in the urine, it would be obvious that the metabolic acidosis was a primary process, or what we call diabetic ketoacidosis. When a primary respiratory disturbance and primary metabolic disturbance occur simultaneously, there is said to be a mixed acid-base disturbance. If these two processes oppose each other, the pattern will be similar to a compensated acid-base disturbance, and the resulting pH derangement will be minimized. By contrast, if the two processes cause pH to move in the same direction, a profound acidemia or alkalemia may result. Metabolic acidosis. A metabolic acidosis is any process other than the rise in the partial pressure of carbon dioxide in the blood that acts to lower blood pH. It is recognized on an ABG by a reduction in bicarbonate and a negative base excess, or BE. Metabolic acidosis may be caused by accumulation of metabolic acids or by excess loss of base or bicarbonate. In the case of increased production or ingestion of acid, the kidneys, if they are functioning normally, have substantial capacity to boost hydrogen ion secretion and may be able to forestall or at least attenuate acidosis. When renal measures are insufficient to prevent a fall in the bicarbonate, there is normally a compensatory increase in alveolar ventilation to lower the partial pressure of carbon dioxide in the blood. If this respiratory compensation is then overwhelmed, an acidemia will result. The severity of metabolic acidosis should be judged according to both the underlying process and the resulting acidemia. A bicarbonate of less than 15 millimoles per liter or those with base excess of less than 10 indicates a severe acidotic process, whereas a pH below 7.25 with hydrogen ion of greater than 55 constitutes serious acidemia. The dominant symptom in metabolic acidosis is often hyperventilation or small respiration owing to the respiratory compensation. Other signs are fairly nonspecific or related to the underlying cause. Profound acidemia, or those with pH of less than 7.15 with a hydrogen ion concentration of more than 70, may lead to a circulatory shock, organ dysfunction, and ultimately to death. The anion gap. In blood, positively charged ions or cations must be balanced by negatively charged ions or anions. However, when the two main cations, sodium and potassium, are compared with the two main anions, chloride and bicarbonate, there appears to be a shortage of anions or an anion gap. The gap is made up of unmeasured anions such as phosphate and sulfate and negatively charged proteins. A raised anion gap of more than 12 therefore indicates the presence of increased unmeasured anions. Every acid consists of a hydrogen ion paired with an anion. For example, lactic acid is the combination of hydrogen ion with the negatively charged lactate ion. Thus, during conditions of increased lactic acid production, there is accumulation of both hydrogen ion causing acidosis and the lactate anion causing the high anion gap. Calculating the anion gap may help to establish the cause of a metabolic acidosis. Metabolic acidosis with a normal anion gap is usually caused by excessive loss of bicarbonate through the renal tract or the gastrointestinal tract. The kidneys respond to the drop in bicarbonate by retaining chloride ion, thereby preserving electron neutrality. Because it entails an increase in chloride ion, normal anion gap acidosis is also referred to as hyperchloremic metabolic acidosis. Metabolic acidosis with a high anion gap is usually caused by ingestion of an exogenous acid or increased production of an endogenous acid. Because the anion that is paired with hydrogen ion to form these acids is typically not measured, its presence leads to an increase in the gap. In high anion gap acidosis, the size of the gap is usually proportionate to the severity of the acidosis. Lactic acidosis and diabetic ketoacidosis are two common and clinically important causes of high anion gap metabolic acidosis. Metabolic alkalosis. A metabolic alkalosis is any process other than a fall in partial pressure of carbon dioxide in the blood that acts to increase blood pH. It is characterized on ABG by an elevated plasma bicarbonate and an increase in base excess. Respiratory compensation or increase in the partial pressure of carbon dioxide in the blood occurs to limit the resulting alkalemia but is limited by the need to avoid hypoxemia. As a consequence, primary metabolic alkalosis is frequently accompanied by alkalemia. By contrast, metabolic compensation for chronic respiratory acidosis is a common cause of a metabolic alkalosis in clinical practice, does not by itself result in alkalemia. The loss of hydrogen ions may initiate the process, but the kidneys have a huge scope to correct threatened alkalosis by increasing bicarbonate excretion. Additional factors that impair this response are therefore also necessary. The usual suspects are depletion of chloride, potassium, and sodium ions, in most cases due to either sustained vomiting or diuretic use. Respiratory acidosis. A respiratory acidosis is simply an increase in the partial pressure of carbon dioxide in the blood. Because carbon dioxide dissolves in blood to form carbonic acid, this has the effect of lowering the pH by increasing the hydrogen ions. Normally, lungs are able to increase ventilation to maintain a normal partial pressure of carbon dioxide in the blood, even in conditions of increased carbon dioxide production. Thus, respiratory acidosis always implies a degree of reduced alveolar ventilation. This may occur from any cause of type 2 respiratory impairment or to counteract metabolic alkalosis. Respiratory alkalosis. A respiratory alkalosis is a decrease in the partial pressure of carbon dioxide in the blood and is caused by alveolar hyperventilation. Primary causes are pain, anxiety, fever, breathlessness, and hypoxemia. It may also occur to counteract a metabolic acidosis. Here's how we interpret the arterial blood gases. There is this systematic approach in arterial blood gas interpretation. The following are the steps, and we are going to discuss them one by one. Step 1 is to measure the arterial blood gas and the electrolyte value simultaneously. Blood for electrolytes and arterial blood gas should be drawn simultaneously prior to therapy. An increase in bicarbonate occurs in metabolic alkalosis and respiratory acidosis, while a decrease in bicarbonate occurs in metabolic acidosis and respiratory alkalosis. Step 2 is to verify the acid-base laboratory values. In the clinical laboratory, both pH and the partial pressure of carbon dioxide dissolved in the blood are measured. Bicarbonate is, however, calculated using the Henderson-Hasselbalch equation. The calculated bicarbonate value should be compared with the measured bicarbonate in the electrolyte panel, and they should agree within 2 millimoles per liter. If they won't agree within the given range, the specimen may not have been drawn simultaneously, or there could have been laboratory error or error in calculating bicarbonate. Step 3 is to determine the acid-base disorder present. First, check for the pH. The normal pH value in the arterial blood is 7.35 to 7.45 millimoles per liter. There is an inverse proportional relationship between the pH and the hydrogen ion concentration. Next, we assess for the presence of respiratory disturbance. A respiratory disturbance is determined by the direction of change in the pH to that of the partial pressure of carbon dioxide. The normal partial pressure of carbon dioxide in the arterial blood is 35 to 45 mm mercury. As a rule, if the pH and the partial pressure of carbon dioxide in the artery change in opposite direction, the primary disorder is respiratory. Then we assess for the presence of metabolic disturbance. A metabolic disturbance is determined by the direction of the pH to that of the bicarbonate. The normal bicarbonate value in the blood is 22 to 26 millimoles per liter. As a rule, if the bicarbonate and the pH changes in the same direction, the primary disorder is of a metabolic component. So to understand what we have discussed so far, let's have an example. So given here is a simple EBG of a patient with a pH of 7.30, partial pressure of carbon dioxide at 55, and bicarbonate of 26. Now we're going to determine whether they are normal, acid, or alkaline. So let's first check the pH. So the pH of this patient is 7.30. Now when pegged to the normal value, 7.30 is below 7.35 to 7.45. So it is said that if it is below that 7.35 mark, it is acidic. Now for the partial pressure of carbon dioxide, we have 55. 55 is beyond the normal value of 35 to 45. And elevation in the partial carbon dioxide beyond that normal range is said to be acidic. Now for the bicarbonate, we have a value of 26, and the value of 26 falls in the normal range of 22 to 26. Thus, it is tagged as normal. So based on the pH alone, we have acidosis as a problem in this ABG. So after identifying that we have acidosis based on the pH, we now assess for the presence of respiratory or metabolic disturbance that have caused the change in the pH. And in this given ABG example, we can see that the partial pressure of carbon dioxide is above the normal value. Now remember the rule that if the pH and the partial pressure of carbon dioxide move in opposite direction, there is a respiratory disturbance. So combining that with that of the pH reading, we now can say that we have a respiratory acidosis in this given ABG. Moving to our next example, CC is a 65-year-old female admitted to Hospital de Alagua with recurring bowel obstruction. She has been complaining of repeated vomiting for the last 6 hours despite taking metoclopramide. Her ABG result is as follows: pH of 7.52, partial pressure of carbon dioxide at 42, and bicarbonate at 33. So we now identify the presence of alkalosis or acidosis in this given ABG. For the pH, it is 7.52 and said to be above the normal value. So it is alkaline. The partial pressure of carbon dioxide is 42 and falls within the normal range of 35 to 45, while that of the bicarbonate of 33 is above the 22 to 26 normal value, so it is also said to be alkaline. Now, looking at the pH, we can say that we have alkalosis. Now, we assess as to we have a respiratory or metabolic disturbance causing the alkalosis. And in this given ABG, we can see that the bicarbonate is above the normal value causing the alkalosis. If you can remember the rule that if the pH and the bicarbonate move in the same direction, then we have a metabolic disturbance. So combining that with that of the alkalosis in the pH, we can say that we have a metabolic alkalosis present in this given case. Next example, we have ROS, a 29-year-old male admitted at K2B unit 5 days after he had an accident where he hit his head on the floor during a basketball match. His ABG upon admission is presented here. He has a pH of 7.38, partial pressure of carbon dioxide of 56, and bicarbonate of 32. Now, what is happening in this case? So, assessing the presence of acidosis and alkalosis, we can see that the pH is within normal range. However, the partial pressure of carbon dioxide and the bicarbonate are both out of their normal ranges. So, what is happening in this case? Noting that both the partial pressure of carbon dioxide and bicarbonate are out of their normal ranges, we can say that there is some degree of compensation taking place which brought the pH back to its normal range. So now we go to step 4, estimating the compensatory response. So when acid-base balance develops, the body attempts to compensate through the buffer systems. The body will try to overcome either a respiratory or metabolic dysfunction in an attempt to return the pH into the normal range. The system can be partially or fully compensated. When the pH remains outside the normal range, it can be partially compensating. But when it is within the normal range, it is a fully compensated state. Here's a table of the compensatory responses in simple acid-base disorders. In respiratory acidosis, the primary abnormality is hypoventilation, and the secondary response by the kidney is to generate bicarbonate. If respiratory alkalosis is present due to hyperventilation, the kidneys will consume the bicarbonate. In the presence of metabolic acidosis where loss of bicarbonate or the gain of hydrogen ion is present, there is an increase in ventilation as a secondary response. And in metabolic alkalosis, wherein there is gain of bicarbonate or loss of hydrogen ion, there is a decrease in ventilation as a secondary response. So in order for us to determine the primary disturbance and the compensatory response, we set the pH normal values to 7.40 as a reference for pH value when both the partial pressure of carbon dioxide and bicarbonate are abnormal, then reclassify. Now going back to our EBG, we see now that a pH of 7.38 is lower with respect to 7.40. Thus, there is acidosis. Now, of the two systems, we can see that the respiratory system is the one causing this acidosis. Remember that if the pH and the partial pressure of carbon dioxide move in opposite direction, then a respiratory disturbance is present. So in this case, the pH went down and the partial pressure of carbon dioxide went up. So there is a respiratory disturbance. Having said that, we have a respiratory acidosis as the primary problem in this ABG. Next, we assess for the appropriateness of the compensatory response. In a patient with respiratory acidosis, the expected compensatory or secondary response is for the kidneys to generate bicarbonate. By mere eyeballing or looking into the values of the ABG without computation, we see that the bicarbonate went up to 35 and the pH is within the normal range, meaning the compensatory response of the kidneys is enough to bring back the pH to a normal range, thus it is called fully compensated. Now, in a case by which the bicarbonate went up but the pH is outside the normal range, it is said to be partially compensated. So in this case, we have a fully compensated respiratory acidosis. Now remember that the buffer system nor the respiratory or renal system has the ability to overcompensate. Here's the formula for the acid-base abnormalities and appropriate compensatory responses for simple acid-base disorders. Now also given is the limit of compensation. As we have mentioned, neither system has the ability to overcompensate. But how do we determine whether the respiratory disturbance is acute or chronic? Hypercapnia or the presence of high partial pressure of carbon dioxide in the arterial blood is due to inadequate alveolar ventilation. Acute rises in partial pressure of carbon dioxide lead to dangerous accumulation of acid in the blood and must be reversed. Chronic hypercapnia is accompanied by a rise in bicarbonate level which preserves acid-base balance. However, patients with chronic type 2 respiratory failure who experience a further sharp decline in ventilation will also have a rapid rise in partial carbon dioxide pressure leading to acid accumulation and low blood pH. In respiratory acidosis, the acute non-bicarbonate buffer response is completed within 10 to 15 minutes, and a steady-state condition persists for 1 hour. If hypercapnia continues for more than 12 hours, the kidneys generate additional bicarbonate by excretion of hydrogen ion, and the maximum level of bicarbonate generation is completed within 3 to 5 days. Thus, respiratory acidosis can be classified into acute if it is less than 12 hours or chronic if it is more than 5 days. As soon as respiratory alkalosis develops, a decrease in serum bicarbonate occurs within minutes. This is due to non-bicarbonate buffering as well as hydrogen ion release from tissues. Lactate is also produced by alkalemia. This buffering from various sources persists for several hours, and the resultant acid-base disturbance is called acute respiratory alkalosis. During acute hypocapnia, the hydrogen ion secretion in both proximal tubule and cortical collecting duct is suppressed. Now, when alkalemia persists, renal compensation starts with a decrease in both hydrogen ion secretion and basolateral exit of bicarbonate in the proximal tubule. This lowers serum bicarbonate even further, due to which the pH is maintained close to normal. The full renal compensation takes 2 to 3 days for completion, and a new steady state is established, which is called chronic respiratory alkalosis. Now, picking from the case where we left off, we have a patient manifesting with respiratory acidosis. But is it acute or chronic? Now, looking closely into the history, the patient had an injury 5 days ago before he was admitted at the hospital. And if you're going to look at the bicarbonate level of the patient, it is already at 32. Now, based on what we have known earlier, if there is already an increase in the bicarbonate and it has been more than 3 to 5 days, it is said to be chronic. Thus, we can consider this case as a chronic case of respiratory acidosis. Now, let's evaluate the appropriateness of the compensatory response of the kidneys. First, how much is the increase of the partial pressure of carbon dioxide from the normal 40? 40 is taken from the average of the partial pressure carbon dioxide normal value of 35 to 45. So the increase in partial pressure of carbon dioxide is equal to 56 minus 40, which is 16. Now we compute for the expected change in the bicarbonate. In a patient with chronic respiratory acidosis, there would be 4 mm mercury change in the bicarbonate per 10 mm mercury increase in the partial pressure of the carbon dioxide. So that will mean 4 times quantity 16 over 10, and it will give us 6.4. And lastly, we compute for the expected bicarbonate, 6.4 plus 24. 24 being the mean and midpoint of the normal value of the bicarbonate range 22 to 26. It will give us 30.4, but the actual range is actually 28.4 to 32.4. Now comparing the bicarbonate of the ABG, which is 32, we can see that it falls within the expected or calculated range. So we can say that the compensation of the kidneys is appropriate and adequate. Appropriate meaning there is a response that increases the bicarbonate, and that is appropriate. Adequate meaning it was able to bring back the pH to its normal level. So what we can say about this ABG is that it is a fully compensated respiratory acidosis, or in other words, there is a chronic respiratory acidosis with adequate and appropriate renal compensatory response. For our next case, we have a pH of 7.53, partial pressure of carbon dioxide of 31, and a bicarbonate of 25. The pH is alkalotic, and the disturbance that is causing the alkalosis is the respiratory system. As you can see, the pH went up and the PaCO2 went down to 31. So this is respiratory alkalosis. But is it acute or chronic? Now looking into the bicarbonate is within the normal range, and the pH is still outside of the normal range. So we can say that probably this is an acute respiratory alkalosis. So in this case of acute respiratory alkalosis, we wanted to know how much decrease in the partial pressure of carbon dioxide is present. So we write the formula 40 minus 31. 40 being the mean and midpoint of the normal value of the partial pressure of carbon dioxide, which is 35 to 45, and 31, which is the partial pressure of carbon dioxide in the ABG, and this will give us 9. So in a patient with respiratory alkalosis, the expected renal compensatory response is the consumption of bicarbonate. But since this is acute, we are going to use the formula delta bicarbonate is equal to a decrease of 2 mg per liter bicarbonate for 10 mm mercury decrease in the partial pressure of carbon dioxide. Substituting that, we have negative 2 times quantity 9 over 10, which will give us negative 1.8. Lastly, we compute for the expected bicarbonate, and that is 1.8 plus 24. 24 again coming from the midpoint or the mean of the normal value of the bicarbonate, which is 22 to 26. And it will give us a 22.2 answer. So, but the normal range of expected compensation is about 20.2 to 24.2. Now, comparing the bicarbonate of 25 in the ABG to that of the computed values, we can see that it is not yet within the range. So we can say that this patient has acute uncompensated respiratory alkalosis. So there is no appropriate or adequate response. Not appropriate because the bicarbonate is not yet going down, and it is inadequate because it was not able to bring back the pH to the normal level. Step 5. Calculate the anion gap. All evaluation of acid-base disorder should include a simple calculation of the anion gap, as these represent those unmeasured anions in the plasma. Anion gap is calculated as serum sodium minus quantity of serum chloride plus serum bicarbonate. The normal anion gap is 6 to 12 millimoles per liter according to Harrison's Internal Medicine 20th edition. The following table shows us the different diagnoses or etiologies causing the decreased anion gap and increased anion gap. One must take note that albumin affects the value of the anion gap. For each gram per deciliter decreased albumin from the normal value of 4.5 grams per deciliter, 2.5 millimoles per liter should be added to the uncorrected anion gap. As an example, we have a patient with a sodium of 145, bicarbonate of 20, chloride of 113, and albumin of 2.2 grams per deciliter. Computing for the uncorrected anion gap, 145 minus quantity 20 plus 113 will give us 12. If we're going to peg it to the normal value of the anion gap, it is normal. However, there is a decrease in the albumin. So the change in the albumin happens to be 4.5, which is the normal range, minus 2.2, and it will give us a difference of 2.3. Calculating now for the corrected anion gap, 2.5 times 2.3 over 1. It will give us 5.75. That 5.75 should be added to the 12 and it will give us 17.75. So the true value or picture of the anion gap is high. So we have a high anion gap in this particular case. The next step is to determine the cause of the high anion gap or the non-anion gap acidosis. For the high anion gap acidosis, the following are the possible causes. Here's the table for the non-anion gap acidosis causes. In a patient with high anion gap, we should compare the delta anion gap and the delta bicarbonate. This is what you call delta ratio. Delta ratio is a useful tool to detect whether there is an underlying normal gap metabolic acidosis or an underlying metabolic alkalosis, or simply put, there is a mixed acid-base disturbance. It's a ratio comparison of the change in the bicarbonate to the change in the anion gap. The formula is given below. Delta ratio is equal to the patient's anion gap minus 10 divided by 25 minus bicarbonate. This is the formula from Harrison's Principle of Internal Medicine 20th edition. Here's how we interpret the delta ratio. If the ratio is less than 1, there is high anion gap metabolic acidosis concomitant with non-anion gap metabolic acidosis. If it is equal to 1, then it is pure high anion gap metabolic acidosis. But if it is greater than 1, then high anion gap metabolic acidosis is present concomitant with a metabolic alkalosis. In patients with normal or non-anion gap metabolic acidosis, we can compare the delta chloride with the delta sodium. If the chloride level also increases in accordance with the decline in the bicarbonate level, then the anion gap will remain unchanged. This is what you call normal anion gap metabolic acidosis or hyperchloremic metabolic acidosis. In patients with non-anion gap metabolic acidosis, we compare the delta chloride with the delta sodium. A way to determine if there is hyperchloremia is by considering the normal ratio of sodium to chloride, which is 1.4. Any chloride level that results in a ratio less than 1.4 would indicate hyperchloremia. Here's an example below. A patient has a sodium of 132 and a chloride of 111. If we're going to get the ratio of 132 is to 111, it will give us 1.2, and 1.2 is less than 1.4. In the same manner, we can also compute that by dividing 132 by 1.4, and it will give us 94.2. 111 is greater than 94.2, so it means hyperchloremia is present. The next step is analyzing the oxygenation. This is useful in correlating the partial pressure of oxygen and the saturation of oxygen dissolved in the arterial blood via the oxyhemoglobin dissociation curve. This is useful in the correction of patient's blood oxygenation level. A partial pressure of oxygen less than 80 mm mercury indicates hypoxemia. As a review, partial pressure of oxygen is the amount of oxygen dissolved in the blood and reflects the gas exchange in the lungs. The normal partial pressure of oxygen should be greater than 10.6 kilopascals or 80 mm mercury. If it is lower than expected, there is hypoxemia. This might be a result of hypoventilation or a ventilation-perfusion mismatch, indicating that there is a type 1 respiratory failure. If the hypoxemia is associated with an increase in partial pressure of the carbon dioxide of more than 6.7 kilopascals or 50.2 mm mercury, there is type 2 respiratory failure. Partial pressure of oxygen is a major factor in determining the saturation of oxygen dissolved in the arterial blood, or the affinity of the hemoglobin to oxygen. This relationship is often demonstrated by the oxyhemoglobin dissociation curve. Oxygen saturation. 97% of oxygen is transported in the blood bound to hemoglobin. The remaining 3% is transported dissolved in the blood plasma. The saturation of oxygen dissolved in the arterial blood is a direct measurement of the ratio of oxygen bound to hemoglobin, expressed as a percentage, and the key means of transporting oxygen to the tissues. The normal saturation of oxygen range is 95 to 100%, and this should always be compared to the fraction of inspired oxygen to ensure that the saturation of oxygen is within normal range. So as an example, we have here a 31-year-old male presenting with lethargy, weakness, labored respiration, and confusion. The patient is known diabetic for 15 years and has been suffering from an intestinal flu for a day or so, for which he has been avoiding food to help prevent further vomiting and make his stomach ache go away. Since he stopped eating, he thought that it would be a good idea to stop taking insulin. When seen in the emergency department, his urine dipped positive for both glucose and ketones, and his breath had a strange sweet, fruity smell. So here's the EBG and the available chemistry of the patient. The pH is 7.26, the partial pressure of carbon dioxide is 23, the bicarbonate is 10, the partial pressure of oxygen is 82, the saturation of oxygen at the arterial blood is 98, the glucose level is 345, sodium is 132, chloride is 83, potassium is 4.9, and albumin is 4.6. So looking at the pH, we see that 7.26 is below the normal value. So we tag this as acidosis. And the one causing the acidosis is a metabolic disturbance. Looking at both the direction of the pH and the bicarbonate, we see that they are both going down. So we have a metabolic derangement. So this is tagged as metabolic acidosis. In patients with metabolic acidosis, the expected respiratory compensatory response is hyperventilation, which is reflected actually in the partial pressure of carbon dioxide of 23. So we are going to compute for the adequacy and the appropriateness of the compensation of the respiratory system. And we are going to use the Winter's formula. It says that the change in the partial pressure of the carbon dioxide is equal to 1.5 times the bicarbonate plus 8 plus minus 2. Now substituting the values of the bicarbonate found at the ABG, we will have 1.5 times 10 plus 8 plus minus 2, and this will give us a range of 21 to 25. Now comparing the partial pressure of carbon dioxide of the ABG with that of the computed value, we see that 23 is actually within the computed range of 21 to 25. However, the pH of the patient is still 7.26, so it is not adequate enough to move the pH back to the normal range. So we can say that this is only a partial compensation. We now have a partly compensated metabolic acidosis. We have an appropriate response with the partial pressure of carbon dioxide going down. However, it is not adequate enough to put the pH back to a normal range. Next, we compute for the anion gap. The sodium is 132, chloride is 83, and the bicarbonate is 10. Substituting them, we have 132 minus 83 plus 10, which will give us 39. With a normal anion gap of 6 to 12, 39 is considered high anion gap. So what we have now is a partly compensated high anion gap metabolic acidosis. Since we have high anion gap metabolic acidosis, we're going to compute for the delta ratio. With the computed anion gap of 39 and the given bicarbonate of 10, we substitute them with the formula of delta anion gap per delta bicarbonate. So we have 39 minus 10 over 25 minus 10, and this will give us 1.93. This is more than 1, so we have high anion gap metabolic acidosis with concomitant metabolic alkalosis. So we have a partly compensated high anion gap metabolic acidosis with metabolic alkalosis. Last but not the least, we check on the partial pressure of oxygen and the saturation of oxygen in the arterial blood. So we see that both 82 and 98 were within the normal range of 75 to 100 and greater than 95% respectively. So we have a partly compensated high anion gap metabolic acidosis with metabolic alkalosis with adequate oxygenation. So wrapping up this lecture, we were able to discuss what is ABG and its importance, discuss the physiology behind arterial blood gases, enumerate and discuss the basic ABG abnormalities, interpret ABG findings, and assess the adequacy of the compensatory response to primary ABG disturbances. And with that, thank you very much for listening to this lecture.